Good afternoon, everyone. Welcome. We're going to go ahead and get started. Thank you for joining us today for our webinar. My name is Karen Bell, and I'm an Associate Director for Partners for Advancing Health Equity. Also known as the P4HE Collaborative, we are a national research learning collaborative that brings together multiple sectors to harmonize health equity efforts and promote actionable solutions. One of the ways we do so is by providing spaces for insightful conversations and disseminating useful resources informed by our research and activities. We are based at the Tulane University School of Public Health and Tropical Medicine, and we are supported by the Robert Wood Johnson Foundation. Today's webinar sets the stage for a series of workshops in the coming weeks on the role of philanthropy in advancing health equity. This series is presented in partnership with Grantmakers in Health, an organization dedicated to helping foundations and corporations, corporate giving programs, improve the health of all people. So before we hear from our panelists, we want to hear from you on this topic. To do so, we will use Mentimeter, which you can access by scanning the QR code on your screen or by going to www.menti.com on your browser or mobile device and entering the code 56094596. So I'm going to do that too, going to menti.com, or I could scan the code on the screen and typing in that number 56094596, hitting join. And once you do, you can hit the thumbs up to let us know that you are there. I see quite a few people hitting the thumbs up. So people are joining that menti.com poll. So we can go to the next slide and show the first question. All right, this should show up on your screen. You can choose which sector to which you belong, or tell us about which sector best identifies your work or represents your work. I'm going to do the same and hit submit. All right, we're seeing these sectors show up. I said academia since I'm a professor here at Tulane, but we have quite a few people from the sector of philanthropy, community, the private sector, some people in government. I think this demonstrates that we are coming from different areas in life or in our work, but the point is that we all want to work together. Okay, all right, I think we can move on to the next question. It says, in a few words, please share your thoughts on advancing health equity. So not necessarily what health equity is, but how do we advance health equity? In a few words, please share your thoughts on advancing health equity, how you're feeling about it, what we should do to advance health equity, maybe even some of the things that are stopping us from advancing health equity. If you have particular thoughts that are related to philanthropy in particular, please feel free to share those. But in a few words, please share your thoughts on advancing health equity. As you can see, a word bubble is being created that is compiling all of our thoughts. We are working collaboratively here, obviously. And so everything that you are putting into this Menti poll is coming up, okay? So I'm seeing policy, collaboration, innovation here in the middle, but I'm also seeing so many other things that are coming up. Funding, anti-racism, feeling hopeful, anti-capitalism, resources, simply that is the right thing to do to advance health equity. Racial justice that is critical, self-determination. I saw so many things are going into this, which we really appreciate. And I think that these things will inform our conversation, obviously. Democracy, definitely seeing that removing structural barriers, it is a group effort, or these are group efforts. I think you could probably interpret that in multiple ways. Decolonizing, yes. What is staying in the middle is policy collaboration. Now advocacy is being added and innovation. So I think that this word cloud is showing us what we think we should be doing and what is necessary to advance health equity. You can continue to contribute to that. I think all of these things, or many of these things, will come up in our conversation. So I want to thank you for sharing, and please continue to share your thoughts and comments in the chat. We specifically have a Q&A box that you can submit your questions to the panel. You can also contribute on social media, either Twitter, Instagram, LinkedIn. I'm not sure if LinkedIn does hashtags, but we use the hashtag partners, the number 4HE to contribute. Okay, so I think we are going to move on to talk to our guests specifically. So I'm going to introduce them now. First, we have Dr. Cara James, who is the president and CEO of Grantmakers in Health. Hi, Dr. James.
Hello, thank you for having me.
Yeah, thank you for joining us. Next, we have Dr. Thomas LaVeist, who is the dean here at the Tulane University School of Public Health and Tropical Medicine. Hi, Dr. LaVeist.
I said hello, and it's a pleasure to be here. And I've now done my one time talking without unmuting, which we all must do at least once.
Yes, yes, it happens to us all. Next, we have Dr. Alonzo Plough, who is Vice President of Research, Evaluation, and Learning at the Robert Wood Johnson Foundation. Dr. Plough, hello.
Hi, happy to be here.
Hi, thank you for being here. Each of our panelists will speak on the challenges that health funders are grappling with as they work to build trust and partner with community organizations to achieve better health for all. So I'd like to start with Dr. James. If you have a few words or some comments to share, please go ahead.
Sure. Well, thank you, Dr. Bell, and welcome everyone. Thank you for taking some time this afternoon to be with us. As Dr. Bell said, I'm Cara James and with Grantmakers in Health. And I want to thank our partners at Tulane University's School of Public Health and Tropical Medicine and the Robert Wood Johnson Foundation, and my colleagues Arpita Jindani and Kate Trainer for organizing this series of conversations that we're going to have. I think that the words that people put into the word cloud around what it takes to advance equity are a lot of the things we're going to be talking about. This is a journey that we are on, and for more than 40 years, Grantmakers in Health has been working to convene health funders on a variety of topics to offer educational programming, learning, fostering that collaboration. I think that we've seen over this time that health funders really have been in the space of health equity for a long time. Obviously, with the pandemic, that has galvanized our work and deepened it for some folks, and for others, caused them to engage more in that work. We find that health funders are on a continuum on this journey, and that we have those who are leaders in this space, such as Dr. Plough and the team at Robert Wood Johnson and others who are a little newer to the space. We think about issues related to trust-based philanthropy, to community engagement, and power sharing, and we're going to talk some more about those, I know, with the panel. But we've seen as well with the pandemic that people have been working to get closer to community and finding in some cases they may not have the relationships that are needed to really help advance the work, and thinking about how they are doing their work from a technical standpoint as well as from the work of engaging and thinking about some of those opportunities. So we still have a ways to go. I think we've also seen in this time people pivoting more into the policy space, which is very exciting and important when we think about systemic change and what's needed for that. So a couple of things just to kind of tee us up, but really looking forward to much more conversation to dive deeper into those. And thank you again for having me.
Thank you so much. Dr. LaVeist, as a dean of a school of public health and lots of experience, what would you like to share to open us up?
Yeah, I've been asked to speak on behalf of community, although I'm an academic, and I know often that there's the relationship between academia and community is fraught. But I have worked with community a lot throughout my career. And in fact, at one point when I was in Baltimore, was literally elected by my community to be the community representative. So I've been deeply steeped in community. And when we talk about this term community in the spaces like this, the term is used in a lot of different ways. And I do want to say a little bit about at least the way that I'm thinking about community in terms of this conversation, which I think can help to structure the conversation a bit. So community can be a community of people. An ethnic group is a community, but that could be national, right? But community could also be geography. And I'm specifically talking from a geography standpoint when I'm talking about community in this specific case. And community organizations can be many different things as well. So you have nonprofits like AARP is a nonprofit. Tulane University is a nonprofit, right? But then you have small community-based organizations. And that's really what I'm speaking about, because that's really the types of organizations that I've mainly worked with throughout my career, these small community-based organizations. And we have this ecosystem, very dynamic ecosystem of community-based organizations that are doing some of the most innovative things that I have ever seen. I'm blown away by some of the stuff that I see people doing in communities. And these types of organizations are the ones that I'm talking about. They have great challenges, but they also have great promise. And one of the biggest problems is the power imbalance. When universities work with these types of communities, the power imbalance is very problematic. Typically, the funding for the project went to the university, where you're having meetings with community organizations, members of the community organizations. All the people from the university that are in that meeting are being paid to be there. The people in the communities are volunteers who are spending their time, to do something that they want to do for their community. And even there is an imbalance. Just there's a psychological imbalance of being at the university, at the Ivy Tower, in this big fancy building, as opposed to holding those meetings within the community or in the spaces where the work is actually getting done. So I think those types of issues are hugely important, and we really need to be working through that. And I think philanthropy can play a role in helping with that. The other challenge I have is, from the foundation standpoint, taking these small organizations seriously. And I can see that, having never been a philanthropist or worked in philanthropy, I can imagine if I was doing that work and I was responsible for grant making. You want to be careful who you give grants to. You want to assure that you're good stewards of the foundation. And smaller organizations often don't have great capacity, and it's difficult for them to demonstrate that they have the capacity to manage these grants. So all of these issues are I think, important to deal with. And I know that there are efforts and programs to help these types of organizations with grants management. And I think that's really critical. But this is a very dynamic set of organizations that are springing up constantly and doing this innovative work. And so we need to make sure that we're devoting sufficient resources to helping these types of organizations to have the capacity to manage the grants effectively. So I'll stop there, and I know there'll be a lot more to talk about.
Okay, thank you. And Dr. Plough, any opening remarks?
Well, again, happy to be here, and I'm probably going to echo some things that my colleagues have already said. I'll tell a little story first. I was giving a talk at a group on the West Coast just last week that included community partners and also their research partners, funded by a federal funding agency. I won't name names, but and there were tensions, creative tensions around how to do what we would call the foundation community-driven, action-oriented research. And everybody believed that's what needs to happen, but our federal partners were constrained in many ways, and even recognized that they were putting undue expectations on their 2 or 3 year in and out grants, as Dr. LaVeist said, which was not appropriately funded for change, and innovation was hard. I share that story because I think that's what on philanthropy, we don't have some of those constraints, and it's really incumbent on us to try to lead the way, both with change. I think there's possibilities, and we work on this a lot at our WJF, trying to influence other funders, particularly some of the federal funders, around how they can do community-driven, community-connected research to action, that this is another kind of rigor. It's not rigorous. And I think that we are trying to establish that this approach to build, we call it more building knowledge toward action, is the way to address issues of health inequity and to build health equity or address problems that we think are root causes of this. And at the Robert Wood Johnson Foundation, we are really focused on structural factors like structural racism and other things that marginalize people into unfair health outcomes. Building the evidence for how you remedy that. We don't need to build any more evidence that those disparities and unfair life outcomes occur. So that's what we're trying to do. But I do think that philanthropy has a particular role around innovation and partnering and learning from communities that maybe other funders, corporate and governmental, have more guardrails. And I think we should be influencing them. Glad that those sectors are on this call.
Thank you all for sort of setting the stage and giving me your opening perspectives. And also thank you to the audience for participating in that poll, because I think that all of that informs this conversation as well. You can, again, participate in the Q&A or even in the chat. That's totally fine. We will try to incorporate that as we can. So my first question actually has three parts. There's three of you all. So I'm first going to direct it to Dr. James or Cara, as you told me to call you. Foundations employ various strategies to address health equity. Based on your experience, where should organizations focus their efforts for the greatest impact?
That is it's a tricky question, because I think part of that is foundations operate in different ways. And so when we think about, if we were to sort of ask even just the audience, as you saw, so many of the foundations and philanthropy were on here, how they go about doing their work, there are a variety of ways in which this happens. Some provide direct services, some provide money for advocacy, some are engaged in other spaces and doing, community capacity building, development, workforce, all of those things. So the first thing I would say is that people need to leverage the strengths that they have. We don't necessarily want people creating new spaces to engage if that's not where their strengths are, but understanding what those needs are. I think I'm slightly biased as a health policy researcher by training. I do think policy is a very important tool, because the systems that we have, as we all talk about structural racism and injustices, are contributing to the bad outcomes that we have and to the health inequities. And so we do have to think about, how do we change those systems? I think that, part of it is also, as Dr. Plough was talking about, the changing the timeline that we're talking about. This is not something we're going to 30, 60, 90 day our way out of. These are problems that have taken us years, decades, centuries to create, and they're going to take us years, decades to address. So what that starts to look like and how we are focusing over time. And I think we've seen more people moving upstream to address those issues. And I think the other piece is we still have to walk and chew gum. So there are immediate needs that people have, and how we address those needs while we are also laying that groundwork and the foundations that need to be done for the broader systemic change that really will have those meaningful outcomes for people. And I think the last thing I would say is to continue to deepen our work with community, to engage them, to approach them cultural humility. Sort of, philanthropy has gone through a bit of an evolution, still on that journey of coming with knowing what the answers are, to now kind of coming in more of an asking, how do we engage in that? And so continuing that work with community to co-create what the focus should be and what those solutions are, because I love getting out in community and saying, you talk to community and like, okay, when we're in our office, you know what the problem is? And then you go into the community, they're like, that is not the problem. Not only is that not the problem, what you're proposing to do is not going to work for these 5 reasons. So how are we working to co-create those opportunities? And the last thing I would say is philanthropy is a bit of a black box. and thinking about how we open up that black box to have a little more transparency to help people see and think about what are the things that we're looking for. Even just, the application process can be a place where there's an equity, because if you don't know a program officer, you don't get invited to submit a grant or those sorts of things. So how are we providing a little more transparency and opening that black box up to work with people to support them?
Dr. Plough, actually, same question to you. Where should organizations focus their efforts for the greatest impact to address health equity?
Yeah, I think that first of all, I think we have to understand the root causes of the current health equity issues, and we shouldn't overlook understanding the history that led and the policy decisions and the structural decisions that led to health inequity in the real time. So part of what I think we need to do as funders is always learn that history with our community partners, acknowledge those harms and build from that approaches. And this would be very similar to what Cara James said. To not come up with our own programmatic abstractions and overlay them on the community, but come up with a collaborative understanding of what might be the best way to resolve the current implications of those historical factors and those structural things that marginalize their community, through a kind of a discourse approach to what you operationalize, and not an approach, as we speak from our vantage point, that is kind of sketched out in advance in Princeton and then kind of taken to some other community. I think that's what we mean when, with philanthropic words like trust-based philanthropy and equitable evaluation. We're evolving, as Dr. James says, as a field, but part of that evolution is kind of moving away from the hubris that the funder knows what needs to happen best, and that is part of the legacy of our history. And then we have an entire, what we at the foundation call a health science knowledge system that formally discounts community knowledge and and community voice in problem solving and research. So we're working a lot on trying to do community power building. It's way beyond empowerment. It's actually kind of an offensive term. I think power building to begin to build on assets in communities to address these issues. Too many of our, I speak as a researcher, too many of our data systems and constructs portray communities as just people who hold on to these disease prevalences. They are not asset oriented and do not capture the dynamics that we need to tap into if we're going to have really innovative community-led action toward addressing health equity. So community voice through effective evidence to effective policy, I think, is what I think you need to do. But root causes and not being afraid to call it what it is, like the legacy of structural racism, really important.
Can I just amplify something that Cara said? She talked about transparency. I think that's really critical. I mean, I think of it as access, but she described as transparency, but it's how to get access to philanthropy. And, that can be difficult, especially for community-based organizations. Universities, we've got systems in place for that. We've got people on staff whose job it is to connect with foundations and know who all the people are. And, but the community-based organizations, it's difficult sometimes to know how to access the foundations, how to even get access to a program officer. It can be complicated. It can be very difficult. So I think efforts to make philanthropy more accessible to especially these types of non-traditional organizations that are doing this innovative work in communities, I think that's where we can find innovation that can really improve, the health outcomes in communities.
Can I just add off of what you just said? As a national foundation, we have to work through local philanthropy. And I know we have a number of folks on the line. When we are trying to tackle a problem in a region or in a place, partnering with local community foundations where the entry points might be a little easier for those residents than it is our system. But I think the challenge is how to effectively get local and how to have a number of kind of inroads into connecting. And we're finding working with community foundations as a way to get more proximate than we are as a national foundation.
Yeah, and I think that's really great, you know, working with local foundations. But I mean, even at the local level, the local foundations are not as transparent and as accessible as they can be either. And some of the organizations that I work with, and some of the organizations that I've worked with, especially here in New Orleans, are fairly well developed organizations. There's one that Karen and I both work with. I was just met with them last week, you know, and they're pretty sophisticated as these organizations go, but it is difficult to build the relationships, even to know how to build a relationship. In some cases, even to know that they need to build relationships, you know, and there is that complexity. And if we can do some things to break down those barriers, I think that, you know, philanthropy, you'll see these organizations with some really innovative and impactful projects and ideas in some cases that can be developed into things that can really be impactful.
Well, I'm rephrasing one of the questions that we sent to you all and combining it with one of the questions in the chat to sort of get at specific successful efforts and approaches. So I guess this is to everyone actually, but are there specific ways that you all from your particular positions have been successful in achieving those aims of actually, for example, Dr. LaVeist, you talked about working with smaller community organizations, and Dr. Plough, you talked about actually addressing the legacy of structural racism. Can you give specific successes in that our audience can seek to replicate or engage with?
So I talked about the power imbalance issue, and I talked about it from two different angles. One is the university to community imbalance. There's that. And then when you bring the philanthropy in, that just creates another layer, right? And so, but I can't speak too much to successful examples that I have seen from the philanthropy side, but I have seen some successful examples with the university community relationships, which could actually potentially be helpful. So when I once had a project where we worked with community-based organizations in Baltimore, what we were able to do there was to deal with this issue, the imbalance in terms of the fact that the university partners were all paid to be in the meeting and the communities were not. They were volunteers. We actually paid them. So we actually wrote them into the grant and said, you know, we will have, you know, people who are community, I forget the terminology we use, but they were community representatives. They'll be actual, you know, actually listed as key personnel on our proposal for this grant, and they will actually get a salary for their efforts. I think those types of things are helpful, making sure that they're a part of the publication, that they're treated like any other member of the team. So how you do that, I think, requires the university person who's running the project to have that sensibility and to be thinking about, you know, community and power imbalances and trying to do as much as you can. You'll never totally eliminate the imbalances, but to try to do as much as you can to make those imbalances as equal as possible. I think that was one successful strategy. I have seen one strategy where philanthropy tried to do something like this, but I actually think it was very unsuccessful. And this was a federal government funder who I'll follow Alonzo's lead and not name NIH in this one. That it was a partnership. It was requiring a partnership between a research university and a historically Black college, and it had other parameters, like the historically Black college had to not have had a certain amount of grant support in the past, and it was a number of things. So it was by definition an organization that didn't have a lot of experience with grant getting, and that organization was required to be the actual applicant, and then the research university was the subawardee. And we was in that type of a situation with a university that didn't have much experience with grant management, and that was not a successful strategy. Now, I think I see what they were trying to do. They were trying to deal with the power imbalance between the research university and the other university, but it actually made the grant very difficult to manage, and you had the grant being managed by an organization that didn't really have experience managing a grant of that magnitude. So those types of strategies can maybe work if they're deployed in some other way that where you're accounting for the potential pitfalls of an organization that's not as experienced managing grants.
I'll give one example that I think is illustrative of a couple of things that are important for us to think about. And this is back from my time when I worked for one of those federal agencies. So apologies if we didn't get things right. But the National Diabetes Prevention Program was initially funded as a demonstration program by Philanthropy, kind of and coming in through a grant. The success of that program then became such that it became incorporated into Medicare benefits. So it is now a benefit for Medicare beneficiaries. That I think is important because that gives it that real long-term sustainability. And so that collaboration to help support the evidence. And so there were multiple folks who were involved in this to get the evidence base, but then to work with the policymakers to get it incorporated into a sustainability model. It has been successful, and that's the reason it was incorporated. But I think the point that I also want to make about this is we do look to philanthropy to fund everything. And while there is a lot of money in philanthropy, it cannot fund everything and it cannot sustain everything over time. And so again, that's why it's important to think about those systemic changes. And so how do we build this into the systems and structures that we have in place to do that work and to think about those opportunities for more public-private partnership and how philanthropy can also help community leverage some of those public dollars to do more of the work and sustainability and work to support the evidence that's needed to translate that into some of our public programs. But that's one example I do think about as very successful from a sustainability standpoint. And as we know, diabetes is huge in our communities, so.
Yeah, this is really an important discussion. I mean, there are just a lot of basic practices that we had to change in philanthropy, and I think we're doing that. One thing that I would say has been successful for us is, and we've had really some good a medium-term kind of influence on this one, is funding community partners with less prescriptive, more general operating funds to tackle a problem in a shared deliberative way with us. And I'll use the example of what, from the technical side, as epidemiologists, we would call sort of the Black maternal mortality problem, but our community partners rephrase this immediately to a birth justice problem. The success in that approach is taking the definition of those who experience this, getting it out of the strictly biomedical constructs. Not to say that there isn't a part of that in the equation, but really understanding the multifactorial context, the life course implications that have led to a problem that I'll just keep this as a sentinel issue, that where we have maternal mortality rates that are much higher than countries in the Southern Hemisphere with far less resources than we have. It speaks to structural problems. It speaks to the continuity of historical marginalization. And I think there is success in developing the right kind of policy and systems change, which our grantees are doing as they broaden their activism and their advocacy beyond just the healthcare system. So that I think that's a really important approach. The other thing we're doing, and I do like to multitask, even though I think the literature says that's impossible. I'm looking at the chat. This part of it is we're working on to change this dynamic. Is what Dean was talking about, changing the institutional practices on the health science side to innovate with those academic partners to understand really how to do deeply engaged community partnered work. And we've got some really good outcomes from I think some of you know about this, the 7 Schools of Public Health Thomas, that we've been working with to really reestablish what they think are acceptable evidence, how they can look at appointment tenure processes so that junior faculty who want to do community collaborative work can actually get tenure, and how they can revision their relationship to community as a partnered co-knowledge sharing. We think that, and Thomas, you know this as well, and the influence that's going to have on the Association of Schools of Public Health, which you are chairing at the moment, I think. That's the kind of structural change that I think is a success pathway. So that's sort of on the academic side. The other was more on the community side.
In that light, another strategy that we have just done, actually, there was a woman who was running a community-based organization here in New Orleans, doing some really innovative citizen science around climate change in her community. And what we did for her was we brought her onto our faculty. So that now this doesn't supplant her nonprofit, which she still runs, and she still runs her grants to the nonprofit. She still, uses the community residents in her work. But if she wants to go for a bigger grant or a bigger project that requires more resources and more infrastructure, she now has the option of utilizing the university as the fiduciary for the grant. She can now access students to help out and access faculty to help out with those projects. And so this is new. I don't know how this is going to work out, but the idea was that we can bring that innovative energy from the community. We can support a community initiative without negatively impacting it and allowing it to go forward and allowing it to continue to flourish, and also support it so that it can get bigger and be even more impactful. These types of strategies, hopefully, as this experiment unfolds, we'll see that this is a strategy that could be helpful as well.
I'll just say, because I also looking at the chat, I will drop in to the chat the link to the Medicare Diabetes Prevention Program for Christina on that. And on the fellowships, I think that is another space we have seen more foundations engage. We used to, I think, have more, unfortunately, fellowships that were focused on health equity than we do now, but there are more that are popping up. And so we have cohorts of scholars and others. I think also for those of you following the conversation around the Fearless Fund, that is also having a chilling effect on programs as people are trying to think about how they can continue the work and move forward with those, but still not shying away from some of those challenges. So there is, I think, that workforce and continuing our own both personal, professional, and organizational journeys around racial equity to help understand, as Dr. Plough mentioned, the history of how we got here and what it takes to move forward is really important.
On the fellowship piece, again, refer you to RWJF website, rwjf.org. We have Health Equity Scholars for Action, young action-oriented knowledge builders. They can be knowledge builders in traditional academic settings or not, which provide 2-year fellowships for this kind of action-oriented research. And watch that page for later in the year for a transformation of our entire research funding program to be a catalyst for kind of a new generation of community partnered research and evidence building. So, which is also going to be supplemented by other kind of fellowship and engagement opportunities. Very important that we grow a new cohort of a policy-oriented, change-oriented. I use the term knowledge builder because it's a little more embracing than the usual constructors that we put on it as academicians.
We need to build a new generation of academic leadership as well. People who are running these institutions, who are thinking about these issues and understand the importance of it.
Yeah, we need more deans like at Tulane.
I
wasn't saying that. I don't know. I don't know.
I can say that. I can say that.
But we need. I think we need to get to the people who actually have the authority to affect resources and get them to be thinking about these issues.
And I would say, even building on that, I think about going back to what does it take to advance health equity, and it's working at every level of the socioecological model. And having people who have that health equity and racial equity knowledge and experience in every single level, because we need community leaders, we need people in health systems, we need people in government, we need people in other organizations and individuals working in all of this. And there's training and capacity building at every level that we can do to advance this work and think about how we build those bridges. And it's one of the roles that I think philanthropy can play, because they sit at the intersection of all of these sectors, of community, of academia, of government, of all of these places. So how do we foster more of those bridges to connect people, to share ideas, to share lessons, to promote what works, and to fund in the gaps where, as Dr. Plough was mentioning earlier, with some of the federal funders who have constraints about what they can and can't do, that can be a place where philanthropy can help out so that we have kind of complete coverage or support in that work. And then we need to also, which we haven't talked about, but I am a data nerd, we need the data. And need to continue to focus on the data, and there are efforts to stop the data collection, but I think that is something we do need, because that research to help support what works can help support spread and implementation broader.
Since you mentioned thinking about this from a socio-ecological model approach, where we look at all of the levels of change that are needed, I want to go back to a question that was in the chat, but sort of expand on it. It's asking about advice to make health services more equitable for HIV populations and LGBTQ communities. But I'm going to rephrase that a bit and ask about funding work that is along that range, but at the meso range or the meso level. So this question asks specifically about addressing stigma and negative social factors. I would say at the community level, what type of funding has been done to address that, and how can we think about actually addressing all of those things at the meso and the macro level, even the policy level?
I'll give one. I mean, those are really important issues. That the question mentioned a couple of groups and conditions that where stigma and marginalization makes access to care and good health outcomes far harder than it should be. One thing that we're doing, we've been doing it for a while, is working with a group of organizations. Includes some funders. It's housed in a special project of the National Academy of Medicine, and it's looking at stigma and marginalization and the social determinants around substance use disorder, and what we need to completely transform and develop a more preventive and less victim blaming approach to a problem that affects vulnerable populations mostly, and gets compounded by using the criminal justice system as a treatment setting and having run many jail health programs. That is not a very good treatment setting for that set of conditions. So that's one, and out of that effort is really something that we hope can work both on the governmental, on the advocacy side, the community side, as well as on the policy side, to really re-envision the way that we need to approach and a non-stigmatized approach to this problem. So that's, but it's very it's marginalization and stigmatization of groups is one of the major pathways to lack of access to appropriate services.
There are funders who are in the space of narrative change and thinking about what are the narratives we have for different communities, different populations, and how that can be leveraged to do more of an asset framing, but also to change those narratives to help garner support for the work. One of the spaces that, and this takes time as well, this is not something that you change overnight, but I think one of the successful narratives that we were able to change was around the uninsured. And this going back to, sort of before the Affordable Care Act passed, where we had people who perceived the uninsured as people who were not working, who were just trying to get government handouts. And I'm not saying we haven't gotten rid of all of that, but part of that narrative that became incorporated with the uninsured, 3/4 of whom have somebody working full-time in their household, to start to change that, to show that it is a group that is very different. That work is happening in other places around racial equity. It's happening in other communities around those with substance use disorder and changes. And it takes time. It's slow work, but it's really important. We have funders who are also funding for if anybody watches television anymore, as opposed to the sort of streaming services and things like that. But in programming, funders are working to get messaging into the programming as well that can help drive some of the narrative change around different issues, reproductive health, maternal health issues, those sorts of things, to raise awareness. So those are some of the ways in which funders are engaging in that.
I want to ask one last question about innovation in collaboration, but I do want to, if one of you all could just quickly answer this question in the chat, because I think it's important. Someone asked, what can be done in terms of funding in a space where there is no data? And they give the example of a rare disease space for Black people, but I think that can be applied to a lot of topics or a lot of issues where the work of getting the data is a lot. And so should we just be funding the solution rather than focusing on getting data? If just one person could respond, that would be great.
I think a little, because I think about, again, another example from my time when I was in the government, the work that we've done on sickle cell in the last 6 years. That is one that is, we didn't have data. Or I shouldn't say we didn't have data. We didn't have a lot of data. What we had was commitment. And there was, I will say, Admiral Giroir really cared about this issue and sort of working with bringing community groups in, helping to push in that space to get some of the gene CRISPR, the work that's happening. That's a place where we've had some success, and the progress that we made in the last 10 years compared to the last 50, 60 years was huge and still needs to be done. I think you still need to have data, because if you don't have the data, you don't know how big of a problem you have. You don't know whether you're making progress on it. And I think there is the need to continue supporting some of that to be able to help tell the story. And it can start off anecdotal, qualitative, working your way up to more sort of quantitative spaces. But at the end of the day, and this is something we can also sort of talk about, impact. How do we measure impact? It oftentimes is, how many people are we reaching? What are the dollars per person? And I think in some of those cases for small populations, rare diseases, rural communities, that's not going to necessarily work.
All right, thank you for that example and responding to that question. I think I will ask this question first to Dr. LaVeist, because this is the point of our collaborative, is cross-sector work. So in thinking about future collaborations and philanthropy or funding, how can cross-sector organizations work together to expand funding opportunities for health equity?
Yeah, that's a really broad question. I think it's around alignment of interests. That's, at least in my experience, when we found collaborations, it's been around having an alignment of interests and skill sets that are compatible. And and so if you're thinking in terms of collaboration and partnership, you want to try to have an impact, and you want to be innovative. You want to think beyond the kind of traditional things that have already been tried. Then you need to be thinking collaboratively. You need to be thinking about, well, who's a good partner? Who's out there doing things that are bringing skills to the table that I don't have? And so that's what my strategy has been, trying to identify who are those compatible organizations and individuals that bring a different skill set, that are compatible skill set, but are aligned in terms of goals.
Anyone else wants to respond to that question? Cross-sector collaboration in funding for health equity?
Just that it's essential because from a social determinants of health standpoint, many of the resources and practices in much of the ecosystem that's responsible for collectively poor health outcomes for marginalized folks are in those other sectors. And then there's, anyone on this call knows that the allocation of health sector funding to equity and preventive approaches is, I wish it was like 10 cents on the dollar, or 1 cent, one cent on the dollar, we'd have a tremendous increase in available funding. So, but it's going to, particularly if it's really about getting to the root causes and changing these conditions in communities, it's going to involve those other sectors. The unfair consequences of financialization of the healthcare system. There are just so many issues that are relating to compounding inequities that we have to get multi-sectoral dialogues and work. We can't do it just on the health side alone.
I think that, during the pandemic, we saw so many sectors recognizing their connection to health and coming in more sort of strongly into the health space. And as Dr. Plough was mentioning, that opportunity for collaborations, I'd say that we need to get a little bit more bilingual and multilingual in how we talk about health and health equity to those other sectors, because the way they approach it is a little bit different. One that I think particularly about is the finance, sort of finance, how they talk about health is not the way that public health and sort of we communities sort of think about health. But that opportunity to leverage their dollars, their expertise, their reach is really important for addressing these, because again, it takes all of us working at all sectors. I think the other thing that is these cross-sector collaborations can also support is leveraging some of those dollars to get them into community. Philanthropy, going back to sort of Ryan White and HIV programming, was able to get those dollars and serve as an intermediary to help get those into community. And sometimes that's a way that can help in that collaboration. We talked about opportunities where there may be things that philanthropy or others can fund that federal partners or state partners can't do, and how do you sort of have a more holistic, for like planning grants or something that not always written into federal grant making, and then working in that community space, because those are the boots on the ground that know what is likely to work, and how we sort of share that power and resources and responsibility across those pieces.
All right, well, I'm looking at our clock and seeing that we are almost out of time. If there were any questions or anything in the chat or the Q&A that we didn't get to, we will actually get to it or address it in our follow-up materials. So feel free to continue to email us or whatever you need to do to get those questions across. But I just want to thank our panel for being here and sharing your thoughts and your wisdom on this topic. We will do a final poll that I believe it is coming up on the screen. You can access it by scanning the QR code on your screen or going to menti.com on your browser or mobile device and putting in the number 5609-4596. You can also click the link in the chat that will come up. And I think we can go to that next question or the next slide. All right. And you can answer the question, what information stood out to you today? And in doing so, I'm just going to give a little bit of additional information about our coming activities, but you can respond to that question through menti.com. With that, we will conclude our session today and invite you to continue the conversation at our workshop series on this exact topic, working with Grantmakers in Health, on September 25th, October 9th, and October 25th. So go ahead and sign up for that. The QR code for the registration is on your screen. We also invite you to join us on October 15th for our next webinar on reproductive justice, which came up in our conversation today as a matter of health equity. More information about our upcoming activities is available on our website. We also have old website or webinar recordings, as well as podcasts and other media. Our resource library is also on our website. You can follow us on social media and help us spread the word by sharing our content that most interests you and your work. All right, thank you all so much and see you soon.